All right, hello. First of all, we just want to thank Dr. Browns and Carol for the introduction and the opportunity to talk with you all today. We're going to talk about transdisciplinary care and the evidence behind this model and the process that our unit has taken to implement a transdisciplinary team approach. But first, we thought it would be helpful to understand the driving forces behind this change. So Melissa and I are excited to join you from Nationwide Children's Hospital in Columbus, Ohio, and we are part of a very large NICU and a large multidisciplinary team that's dedicated to the NICU. Additionally, we've spent the last 2 years working together with our nursing partners as developmental coordinators on the BPD unit. Our medical director, Dr. Susan Lynch, created this role to respond to the evolving complexity of the patients and families during their long-term stay. These infants are diagnosed often with super severe BPD, which means that they still need positive pressure at 3 months of a corrected age. So therefore, they spend months to years on our unit while their lungs are still growing and developing prior to ever getting discharged home. But this hasn't always been the case. 10 years ago, the majority of our census were infants less than a year old. They were typically on nasal cannula or they were weaning from their nasal CPAP, and they had transferred from within one of our units or other hospitals within Central Ohio. Maybe 3 or 4 of our patients had tracheostomies or were on ventilators. But as of today, our unit currently has 13 patients on ventilators, 8 of which are over a year of age. So our BPD team has had several publications, and thanks to social media, parent word of mouth, and their satisfaction, we've begun admitting patients from all over the nation, as you can see on this map. This is in our nurse practitioner office. But these babies also had the additional challenge of weaning from sedation. Most nurses, therapists, and doctors realize that this comprehensive center for bronchopulmonary dysplasia is not just the traditional NICU care that we all signed up for. So for all of these reasons, a need to further evolve our services and our approach was identified not only for our families, but just as importantly for our staff. We really needed to transition. We asked ourselves, how could we do better with our critically ill infants from outside institutions that have a prolonged length of stay? How can we assist and support progress and collaboration between the staff and the families? Yes, the babies on our unit were more sick and they needed to stay for longer periods to wean to safe homegoing parameters. But how could we maintain and even improve on our initial level of satisfaction with a higher level of acuity? So to respond to these complex needs, we initiated several programs before we began to research different models of care. We started identifying services to meet the complex needs of these patients. So this transition began in 2014 with our SOAR program, which stands for Support, Organize, Assist, and Regulate. And this is just when we added a second person to support during routine cares to maximize neuroregulation of the infant and physiologic stability. This required all of the caregivers to identify the infant's specific needs, and the overarching goal was to minimize sedative interventions. But you can imagine that this is also maximizing the therapeutic role of the caregivers. Soon following, we created neurodevelopmental rounds to address infants with significant regulatory deficits. We have a neurodevelopmental pediatrician on our team, and more recently have added a behavioral psychologist. We also realized that we needed developmental PCAs to support the global developmental needs of these complex patients. But we also needed to support the parents. We've added psychology services, we've evolved the roles of our parent advisors in pastoral care, and we established a role of the parent navigator. So we started these programs and we increased our developmental support, but we all know that development does not occur in a vacuum. It's not independent of the complex medical challenges that are occurring simultaneously with our infants. As you can see here, we are blessed with a tremendous amount of resources. But each one of these caregivers comes with their own agenda, their own goals, and their own tasks to complete. Yes, each of us carry a unique role and a unique perspective. And we know that each interaction with the infant shapes responses and outcomes. Some of these pictures are on the bottom of one of our favorite little friends, and his most recent preschool picture, his mom has said to us, this is the long-term vision for each and every one of us. But we also know that we aren't going to be able to see measurable progress if we aren't able to clearly and consistently communicate. Frequently, we hear the medical team asking, well, how is the baby doing today? And to one provider, they may think of, oh, how did they sleep last night? Another might think of, how are they breathing? Another will think of, did they gain weight? Or how's their oral feeding? Oh, are they able to interact? So we're all likely to answer this differently and within our typically defined roles in our training. But according to NDT principles, development occurs when a child interacts not only with his or her environment, but also with his or her caregivers. This is especially important when children grow and develop on long-term care units. If a parent, in our case, sometimes the nurses, are educated and they can respond to the baby's cues and facilitate self-regulatory behaviors, there's a better chance for motor learning and ultimately improve long-term developmental outcomes. We know that no amount of treatment can be effective unless the progress in which the child makes during the treatment is actually carried over into their everyday life and activities. Again, this is especially important because our babies' caregivers are not only their parents, but also their nurses and therapists. We are sure that each of you could share a story of a baby you wish had the benefit of repetition, that consistency of caregiving. For example, you are trying to address a positioning plagiocephaly, or you are trying to really be consistent when feeding a fragile infant. So as we looked at the needs of the babies, we realized just how instrumental clear communication would be to our success, as well as working towards a common goal, to truly function as a team, individualizing our care to each baby. So every unit has room for improvement, but it's also important to look at what already exists as an area of strength. For our specific unit, we recognize that our nurses had a unique and specialized skill set in regards to their care and assessment of infants with BPD. We also had nurses that had infant and toddler developmental knowledge, which was applied to their assessments. And we really had a unit commitment and culture that supported parent involvement. But building from what was already established on our unit, it was identified that we had definitely some areas to grow. We needed to streamline our communication between all disciplines. We needed the nurses to be able to communicate their assessments beyond just a doc flow sheet. We needed consistent integration of nursing assessments in our group discussions and bedside rounds. And we needed parents to get more routinely involved in goal setting for their own baby. So we had to be creative. We were given some resources that we may not have asked for, and this was based on an increase in our nurse-patient ratios. And we also had resources that were not trained for the specific needs for the babies on this unit. So we had to ask ourselves, how do we train, incorporate, and support all of these resources into one team with the same values and individualized approach to care? So we investigated team models to determine the best fit for our unit. The terms multi, inter, and transdisciplinary are often used interchangeably, as if they are the same. But when we really investigated the literature, it was found that the definition of these terms were really quite different. To start with multidisciplinary teams, this is the simultaneous contribution of team members to the neurorehabilitation hurdles that fall within their traditional disciplinary scope of practice. So you can see on this pie chart that there are many caregivers, but each one of them tend to operate in a silo, working with only within our traditional roles, which makes it a challenge to monitor change and create success for very complex patients. In the communication on the bottom right of the slide, is typically in the form of an order from the physician, and then we give feedback to that individual provider. And that is if we can catch them in rounds or they read our notes. So interdisciplinary teams recognize that some overlap of these roles was beneficial. To be honest, this is the way most NICUs work. We work with each other, there is a little overlap, but we generally remain within our specific roles. So transdisciplinary teams, each team member is responsible for every clinical concern. So transdisciplinary teams are transcendent and they involve flexibility and accountability. It truly is a shift in thinking because there are no boundaries. It requires excellent communication to achieve this level of integration, and it begins with the entire team aware of the patient's primary goal, and that's represented on the right here with that first issue 1. And then their ability to use their specific skill set to address that goal. So we'll go over some examples of this a little bit later, but in addition to knowing the goal, there needs to be a format for communicating how the patient is progressing towards that goal. So as you can see in this diagram on the left, each discipline needs to have ongoing communication with one another. And I love that this model includes the patient and or the family represented here. It's not people talking around them, but they are part of the team giving feedback along the way. So fortunately, our unit had some infrastructure in place already. We have a weekly meeting where each provider gives their impression of the baby's progress over the prior week. We call this our subgroup meeting. And we also have a monthly big group meeting to summarize progress and barriers to progress over the past month. But that prior picture of all the caregivers in a circle discussing the patients really reminds me of this picture of everyone talking every week about the babies on our unit. So many of us have heard of a transdisciplinary model in association with an early intervention model of care. So we wanted to briefly touch on what we were able to find on this topic as we tried to compare how it's used in a home-based setting to what has been done in long-term acute care settings. So first, let's look at the similarities. One is that both settings, there is a development of a mutual vision or a shared meaning among the team members, with the family considered to be a key member. This would look at, in our unit, would be the primary developmental goal. Secondly, there's intensive ongoing interaction among team members from different disciplines. This enables them to pool and exchange information, knowledge, and skills to work together cooperatively. So let's look at a few of the differences. The first being that in an early intervention model, one operational feature is an arena assessment. In an arena assessment, professionals from multiple disciplines assess the child simultaneously using both standardized measures and informational methods. But this is not typically how we practice in a NICU. And secondly, there's the concept of role release. This includes letting go of one specific role when appropriate for other members of the team to support. This also includes releasing what we know to the family to practice. Role release sounds easy, right? But it's really a very complex process that includes this role extension, role enrichment, role support, role expansion, role exchange, and then finally, the ultimate goal is role release. But this type of intervention seems most appropriate when babies are more stable and are at home with their families. Okay, so we've looked at some models of care and we've compared transdisciplinary models in various settings. So we hope that this is getting you thinking about what this could look like possibly in your NICU. But before we wrap up the literature review, we are all driven by the need to improve our outcomes. So we wanted to know, are there any outcomes reported with the provision of a transdisciplinary model of care? And fortunately, there are. This is just one example in the literature from an Alzheimer's unit, because the research thus far has been documented in rehabilitation and long-term acute care settings. In this specific study, the patients with Alzheimer's disease reported feeling less stress about their memory problems. They were more confident in their knowledge about Alzheimer's disease and related disorders, and they also reported less depressive symptoms when being a part of a transdisciplinary team. But we were also really excited to see that caregivers also had noted improvement in 5 different domains with this collaborative care approach. 1, caregivers were less frustrated when dealing with the patient. They reported less uncertainty about what to do with the patient. They were less concerned that they were not doing enough for the patient. And I think sometimes as medical providers, we all feel that we just aren't doing enough. All of the caregivers reported a better sense of control, and they were more confident about finding sources of support. So you might be asking yourself, exactly how does an Alzheimer's unit compare and apply to our NICU? But as therapists, during this very vulnerable period of brain rewiring and neurosensory development, we would support that a NICU is an acute, long-term rehabilitative setting. So what does the process for change entail? For us, we started by forming a planning committee, and we did this in 2016. I think it's very important to remember we need to include key players, including administration and physician leadership. And we started out with some quality improvement concepts using key diagrams and visions, creating a vision for our change in practice. As a committee, then, we decided that the initial goals of this transition to the transdisciplinary model were going to be to establish a form of excellent and sustainable communication. We worked actually with our rehab unit to see what had already been created and learn from their successes and their challenges. Then our planning committee continued to meet weekly to keep up our momentum and our accountability. This is a diagram of our key driver diagram that we put together. And we know that practices such as PDSA cycles and key driver diagrams that are instrumental in quality improvement initiatives are not always natural processes for therapists. But we have found that it was critical for our planning committee to clearly define our goals, acknowledge our deficits, and really recognize some potential interventions. In our setting, this leadership was provided by the therapy team. So ask around in your setting. Maybe your neonatal team or your hospital has a QI role or a facilitator that would be willing to help you get started. So we continued on, and we mentioned that communication was a challenge between the day shift nurses, the night shift nurses, and the multiple different providers. So one of our first goals was to tackle this barrier, and we created a nursing shift summary as well as a BPD team assessment. This was a place that we could share information from the week, even if we could not attend that subgroup in person. The medical team then integrated this input into their decision-making process, and you'll see an example of this in a few minutes. Then we started talking about the transdisciplinary model of care. First, it was informal at the bedside, then through some more structured services, and there was some initial interest, but we also felt that hesitation. People had that questioning look. Will this make more work for us? Will it be helpful? Maybe it'll just go away. So we decided we really needed to practice it and really get the feedback from the entire team through the process. So we identified 4 transdisciplinary pilot patients. So these 4 cuties were our 4 pilot patients. So in addition to looking at how to actually apply this at the bedside, we also wanted to take some different measures by staff and family surveys. We asked the parents to be a part of this process and give their feedback as well. This also included the parents' need to assist us every month with goal setting, but then also following through with the activities they identified as most important to them and that were identified to help them meet their goals. So helping the family choose a goal is tricky. And I would say that the overarching theme needs to be to help families pick a goal that each of the caregivers can participate in, because this is what makes sustainable change. because we know that care protocols should be patient and family-centered. They should be individualized and incorporate input from the patient and caregiver in a shared decision-making process.
We were able to share one parent's perspective on what it meant for her and her baby to be a pilot patient in a transdisciplinary model. As you may be able to see in this video, her baby has a high level of involvement, and it was especially difficult to monitor and determine this baby's gains across disciplines before we identified a primary developmental goal. Here's what this parent thought following several months of integration of the transdisciplinary model.
Tell us how it has been for you having a primary developmental goal for Mr. Bryce.
Well, when we first started that, I felt that that was such a great new idea. I think the one time we had it to begin with that just made it evident how powerful it could be was when we had it be, Bryce was having a hard time with bringing his right hand to his mouth. And so all of the different disciplines were asked to be on his right side and have his hand be involved, and over time it became actually slightly easier for him, and so I was able to actually gauge kind of improvement from that whole exercise, and it was very evident. So that was really nice and positive to see.
Awesome.
Parents provide a perspective of their number one concern. And from our experiences, this is often a concern that can provide a great deal of insight regarding their baby's progress. However, this is a discussion that requires an open dialogue and trust between skilled caregivers and the family, and also skilled perspective and assessment from the therapist to adapt the parent's vision into something all of the team members can apply. So therefore, OT, PT, and speech can be the drivers of this goal development by meeting with the families consistently to discuss their primary goals for their baby, by modifying that goal based on the baby's medical stability and the developmental appropriateness, also being the communicator of the goal to all the team members in the forum that is available in your setting. You may also have to work towards obtaining any orders that may be necessary to support this baby's goal, and ultimately working towards facilitation of incorporation of this goal into the baby's all-day daily routine, not just during treatment sessions. As a reminder that development occurs when treatment is carried over into daily activities and not just in the context of one treatment session. As you notice, we use the word therapist and often say OT, PT, or speech. In the transdisciplinary model, we're able to apply our specific skill set and also overlap to support the infant's primary goals. Therapists, of course, are obligated to maintain discipline-specific goals. However, we can all support the patient's primary developmental goal. For example, the infant's primary developmental goal may be to reach full PO feeding. How might a PT support? The PT may provide assistance during cares to facilitate infant regulation and organization and provide support for energy conservation in preparation for oral feeding. The OT or the speech therapist can provide the feeding intervention or the parent coaching. And the speech therapist and OT can also collaborate closely on a patient's case, providing complementing services and also carryover for recommendations, with the thought that development will occur most rapidly when incorporated frequently during all interactions. And I've also left you with a neonatal therapist definition as defined by the National Association of Neonatal Therapists. The nurses, the neonatal nurse practitioners, the medical physicians also have roles and accountabilities. So the nurses and the PCAs, this goal is requested to be part of the handoff. incorporated into all of their interactions with their baby, and for them to provide feedback to the team based on their own skilled assessment. The nurse practitioner and physician can maintain these primary goals as a basis of discussion for all rounds. And again, this idea of all speaking the same language. In terms of accountability, the rest of the team is in the role of knowing the goals, knowing how their specific skills can contribute to the primary medical and developmental goals, documenting the baby's responses towards the goal during your interactions with the baby, and of course, always reporting on this. So let's take a look at how the transdisciplinary model can look like in the NICU. This infant, born at 24 weeks, she is now 30 weeks, and as you can see, intubated. The mom's primary goal was to provide direct breastfeeding. The primary therapist involved with this family helped to modify this goal based on where the baby was medically. Therefore, the goal was established that the mom provide at least 1 hour of kangaroo care daily while the baby receives gavage breast milk and tastes on the pacifier. So this is what it looked like. So the therapist's involvement was to provide education related to the appropriate supportive practices for breastfeeding while the baby was still intubated. And that was skin-to-skin care. Also, assessment of the baby's responses during skin-to-skin care with taste of breast milk, and supporting the mom during the experience to promote confidence. The nursing role in this circumstance was assisting in determining of timing of kangaroo care based on this baby's cares and schedule that day. They were able to direct the transfer, and they were able to provide developmentally supportive cares along with the therapist and mom to promote this baby's regulation and preparation for the transfer. The medical team ensured that orders were in place to support this task, and lactation provided ongoing involvement to support pumping. So how would something like this look in our documentation system? And a strong focus of the transdisciplinary model, and therefore our education, was communicating a way we could, again, all speak the same language and be on the same page. To demonstrate how this could happen, we've included a portion of our BPD team assessment that includes the goals for the baby at the top. And then underneath, the nursing shift summary that's completed at the end of every shift. So you see for this baby, their goal was to have supported sitting opportunities with each daily care. And then the nurse is able to comment on this baby's progress towards that goal from their perspective. And the nursing assessment in a comprehensive way is very important to add to the view of goal progression and the barriers that may be identified in reaching this goal. So let's go ahead and go through how this all essentially can work together. And remember, the goal provides context from which we all speak about. We know there are so many important elements. However, this is to help focus our thoughts. And through these discussions, we're able to provide information regarding other pertinent concerns. So first, at the top is establishing the goal, talking to parents, putting them first, also including primary caregivers, and then shaping that goal. Next is communicate. This could be at the bedside, in orders, during nursing handoff, and during discussions with staff. Then facilitate goal-focused discussions, finding that forum ongoing. Use the goal as a basis of discussion when you're speaking with the family and staff. Their perspective is within the context that they interact with the baby, and they add so much information based on how the baby responds during different times and interactions. Also, developing and establishing forums in which multiple disciplines can provide their assessment of the progress towards the goal. Asking the nurse, is the baby able to stay calm and alert during cares with support? What do you think the barriers are? What does your area of expertise add to progress or intervention? And then ultimately, again, this phrase that we're all speaking the same language, and knowing that there are all these elements to consider when looking at the baby, but using this goal to focus our thoughts. Now we're going to discuss a case study, and this is Cora. She was born at 24 weeks. She was mom's first baby after trying for 7 years. Baby's now 31 weeks in the upcoming video, and mom's goal when she gave birth was to provide direct breastfeeding for her baby. However, she's coming to where she's been able to provide less than 15 mL of breast milk with pumping daily. Mom was able to understand that her baby would need formula supplementation, but it was really important for her that Cora's first oral experiences be with breast milk only. So we helped shape the primary goal for Cora to experience taste of mom's breast milk with care. And here is a video of Cora receiving oral care. In this video, this is mom's hand that is providing the oral care. It's the nurse that's providing the hand containment during the care. Therapy prior to and during this provided education and coaching regarding a gentle approach to oral care, gradual introduction of the swab, and pausing to allow for sucking opportunities. They also provided ongoing support and education for providing this hand containment during care. Again, lactation had an indirect role, and the medical staff was aware that tastes were being provided while this baby was intubated. They were supportive and provided the orders to ensure this was happening. Now you may remember that Kelly spoke about role release, and in this slide we call it role flexibility. We're going to look at the video of how she accepted the pacifier. This baby received preparation and support to accept this. And I just want you to think about how these traditional roles were modified at the bedside. And this baby ultimately was able to remain relaxed and ready to accept the pacifier. And our goal was achieved. Regulated
It's up to you. Oh.
As you may be able to recall, we were able to provide education during a staff retreat regarding transdisciplinary model and implementation. And we compiled some information from the staff surveys from before the concept was even introduced informally, that's in the red. Then another survey after the pilot patient trial, that is the yellow. And then a post-transdisciplinary education survey, and that's in the light green. And you can see that in every area there was improvement. So looking at satisfaction regarding the staff's knowledge of the patient's developmental goals increased, where to find the information regarding medical team updates increased, the perspective of value of the primary developmental goal also improved, and their knowledge of what to work on with this baby also increased. As well, a parent survey was provided before the transdisciplinary model was implemented, and then again after we provided staff education. And in this, we saw an increase in satisfaction regarding their baby's developmental goals, an improvement in their perception of staff knowledge of development, an improvement in their perception of adequate staffing to support development, and also increased understanding of skills to work on with their baby. And here's a video of a mom's satisfaction following incorporation of the transdisciplinary model.
All right.
Okay, so the primary developmental goal, getting everybody involved, has been amazing. Because I feel like since we've started doing that and having everybody address it, it's basically, instead of having somebody address it once or even twice a week, it's everybody across the board, and she's seeing it at least once a day when it comes to either nursing or PT, OT, even music therapy. And so I feel like she's progressing a lot quicker now with her issues she was having. Yeah, I think that's the main thing. It's just everybody addressing it, and it's just been more consistency instead of just once a week or twice a week. And it's definitely helped her get to where she needs to go much faster. Raven, what are you doing?
Thank you so much.
Thank you.
So you've seen some of the parent satisfaction. We were also, of course, curious about what the staff thought would be when asked how they would apply one concept learned during the staff transdisciplinary education. And just to make it clear, the staff education was not just nurses. It included all members of the team, such as dietitians, pharmacists, and respiratory therapists. And the question was posed without an answer to choose from. And these are some of the topics that were written in. Half of the comments included that staff understood the importance of working towards patient goals. Almost half of the comments included their willingness to use the shared BPD team form. About 1/8 of the comments included understanding of the transdisciplinary model of care. And also several comments included awareness of how this model of care can impact and improve communication and one team values. So as we start to wrap up, we wanted to review a few key concepts. A reminder to be creative and flexible in our roles. As therapists, we can be parent coaches and advocates, which can be even more of a priority than hands-on care. And that the result of our care is reflective in the outcomes of these infants. So I'll briefly share a study that was in Amsterdam with 176 infants, less than 32 weeks or less than 1,500 grams. It looked at use of the Infant Behavioral Assessment and Intervention Program, which is a basis of training that was provided to parents. The training included the need for the parents to support their infant's self-regulatory efforts, also the parents' ability to adjust the environment to support their infant's specific needs. It also supported positive parent and infant interactions, and enhanced postural control and successful infant explorations without distress. This multi-center study showed gains in all areas of development at 6 months for these infants, and in the motor areas at 24 months. They were also able to isolate the BPD patients to identify that infants with the comorbidity of BPD profited the most from the intervention, as they are particularly vulnerable to stress. Therefore, our highest risk populations absolutely need our support and education. Progress, again, is not just within the isolated context of our interactions with the baby. When we see the parents as primary caregivers, and we can identify regulatory support as a basis from which a baby can make progress, and engage all caregivers to participate in this, our outcomes ultimately are improved. So in the transdisciplinary model of care, it does require teamwork that captures trust, communication, and collaboration, because team members are crossing some traditional disciplinary boundaries, which can be scary. However, we're promoting this because we believe the result is the opportunity for focused care to support best outcomes for our very sickest babies. And in the end, thank you so much for joining us today. And we hope that this adds to your inspiration of how you can make even more of an impact in your day-to-day.